Hello and welcome to the latest in our series of NR Times Roundtables discussions. And today we're focusing on surviving brain injuries and rebuilding lives and families. Specifically today, we're going to focus on how brain injury impacts not just on individuals, but on families, loved ones, and those close to them as well. I'm delighted to say that we've got a fabulous group of panelists with us today with a wide range of experience, and happily they've agreed to share that experience and their insight with us today. So I'm going to ask each of the panelists just to say a few words about themselves, their organisations, and their areas of specific interest. And if I could start with you, please, Eki.
Good morning, everyone. So I'm Eki Popat. I'm Registered Manager and Operations Director for the BIS Services. We're cognitive specialists of brain injury in the community. So we provide cognitive rehabilitation assistance to work with individuals and their families to work with functional skills, especially strategy implementation. So that's our key kind of interest. And we do really specialise in independent living assessments and trials. So really looking at support needs long-term for clients and their families.
Great, thanks very much, Eki. If I could come to you next, please, Casey.
Of course. Hi, Alistair. I'm Casey. I'm the Business Development Manager for Steps Ahead Care and Support. Quite similarly to BIS Services, actually, we are specialist providers of brain injury and spinal injury rehabilitation in the community. So we work quite closely with MDTs to kind of implement those prescribed therapies in the home, and work on independent living trials as well to transition people from kind of inpatient rehab settings back home to their families, and working with their families to adapt to that as well.
Great, thanks, Casey. Natasha.
Hi, I'm Natasha. I am the therapy team lead here at Kingston Rehabilitation Centre under CHD Living. I am a physiotherapist by trade, and we work with a wide range of brain injury and spinal cord injury here in our service. So we have a rehabilitation level 2 pathway, and we also do a lot of disability management, helping people transition from the sort of acute care setting to try and get them home and set up for their lives going forward as a sort of an interim placement until they can be found a place in the community.
Thanks very much, Natasha. And Hugh.
Hello, my name's Hugh Ponting. I'm a partner and head of the personal injury team at Enable Law. Enable Law has quite a specific focus on just 3 core areas, which is high value and complex personal injury and clinical negligence, and also a well-regarded mental capacity court protection team. I'm also a court-appointed deputy as well as a litigator.
Thanks very much, Hugh. And Pedro.
Good morning, everyone. My name is Pedro Grillo. I'm a consultant clinical psychologist, and I work for Richardson Care. I also have a post within the NHS, but today I'm representing Richardson Care in Northampton. So Richardson Care is an organization that provides neurorehabilitation for adults that sustain acquired brain injury. We have acute services and what we would describe as home for life. So we have that pathway from immediately after the accident. We follow the journey of recovery, and after that, our service users are discharged to the community. Normally, we are thinking, in fact, develop our services to provide community support. That is part of our plans, but mainly is what we do. We also have a service for people with learning disabilities.
Thanks, Pedro. And finally, Salman and Micah.
Hi, good morning, everyone. My name is Salman. I'm the General Manager and Head of Therapies at Ascot Rehab. Ascot Rehab, and we provide outpatient and inpatient rehab for a wide variety of conditions, from neurological rehabilitation to MSK and orthopedics. We do also provide outreach services as well to the clients to really follow that sort of journey from acute to inpatient rehab to outpatient, and then eventually seeing them in outreach setting. Yeah, basically that's pretty much it in a nutshell about Ascot Rehab. Yeah.
As you said, we have a wide range of indications. Obviously, brain injury is one of them. We admit patients from the acute hospitals when they are surgically or otherwise safe and stable to be transmitted into a rehab setting, from UK settings and also international settings.
Great, thanks Salman and Micah. I'm going to go around the panelists just to kick off our discussion and ask each of the panelists just to say a little bit about the key issues and the challenges with reference to how brain injury impacts not just individuals, but families and loved ones. And I'm conscious that as we go around the panel, it probably becomes more and more difficult to say anything original and unique. So, you know, feel free to weave around what other panelists have said, and then we'll open up the discussion. Eki, if I could start with you again, please.
Yeah, of course. At the BIS Services, as we do community work, the family is at the heart of what we do. They're actually at the process from the beginning. So as soon as we get a referral to work with an individual with brain injury, we involve the family because, as you know, they are the people that have actually been supporting that client before we have. So their insights and their knowledge is key to actually how we start to work with their loved ones. So when we have a potential referral, we actually get them involved in the recruitment. So what are their preferences? What do they feel that their loved ones needs? Actually actively listening. And actually, I think that is a key to building successful rehab programs, is involving them. And I think one of the biggest challenges we've had is when there's a significant wide MDT and there's a lot of different members, and actually getting everyone involved and heard and actually being in line with everything and having a consistent approach is probably one of the most difficult things. So actually involving them from the onset has been a very successful approach of ours. And I would also say as well is it's been creative with families. So we're not sometimes always there supporting the loved one. So actually getting them involved and embedded with actually what the program is. So what are the strategies being implemented? What are the goals? And being creative with them of how they can also facilitate that when there is no MDT or support. So they feel a part of the team, but also actually can feed back to us of actually how they find things are going. So they're not just feeling like a bystander, but an important part of the MDT themselves. And again, that's really worked really well of them being embedded into the strategies. And I think one last example I'll mention is in our independent living trials, where families can be highly anxious about letting their loved ones move away for even a short period of time, because they are naturally really concerned and worried that will they get the support that they've been providing with people who don't know them as well. So it's about reassuring them, and we do that by actually incorporating family days in independent living trials. So what we do is a part of the weekly program, we look at what day works well, and we actually look at their goals. So it could be maybe the OT works on cooking skills, and we actually make like maybe a Wednesday where the actual client actually cooks a family meal and the family come over. So rather than the family always having to cook for the loved one, now it is roles reversed. And we're actually empowering the client to invite their family over and showing their skills. And that's worked so lovely. And I think it's actually strengthened the relationship, because it's gone from now the family being carers to more being family and parents, or, you know, a partner. So actually empowering them to establish that relationship better, and us having to be that more scaffolding has worked really well as well.
Great, thanks for taking the discussion there, Eki. Casey, if I could come to you next, your perspective on the big issues and challenges.
Of course, thank you. I mean, I think the main thing for us in terms of an issue and a challenge can actually be, I mean, outside of the clients that are going through the litigation process, where we may be funded by a defendant insurance company, is actually clients who maybe don't have access to that, and they are looking at kind of local authority funding and things like that, where they may have a meeting with a social worker. And as you'll all know, a lot of people who have sustained a brain injury can present with frontal lobe paradox. And that social worker will go in and just not understand why that person needs a level of funding. And the social worker will go in and say, oh, you know, well, they can make a cup of tea, they can take themselves to the toilet, and they've greeted me at the door, so they don't need any care. And I think a huge thing that I think we could all work on as a collective is actually increased education in the local authorities and the social work sector around brain injury, because it is such a huge challenge for us, where we are constantly having to put up a fight to justify why that person may need funding and that extra level of care. And I think there's a very reactive approach in local authorities where, well, nothing's gone wrong, so we're going to take the care away, rather than actually recognising the reason nothing has gone wrong is because that care is in place. Sometimes a lack of evidence is evidence in itself. And I think we need to kind of shift local authorities and councils and CHC as well, their perspective on actually how funding is looked at, especially with brain injury, because no matter how many professionals are in it, it is, I think, still a relatively unexplored area, and where, depending on what part of the brain has been damaged, can present so differently. It's really difficult in a short assessment for social workers or commissioners to pick up on a level of need that is there, that can go unrecognised in a short assessment. Another thing we found, which Eki did touch on, is kind of family pushback as well, where, you know, yes, this person has sustained a brain injury, but it's also the trauma for the family. They are grieving the person that they were before that brain injury. It could be their partner, it could be their son, mum, dad, uncle, aunt, whoever it is to them. They are grieving that person and having to relearn the person as they are now. So you end up kind of supporting not only the person that has sustained the brain injury, but the family as well, and supporting them kind of through that grief process. And like Eki said, becoming scaffolding for the family. So we've implemented kind of just drop-in coffee mornings, not only for people who have sustained brain injuries, but families, where they can kind of get how they're feeling off their chest, because those feelings of resentment are so prevalent. You know, if this didn't happen to you, my life wouldn't look like this anymore. And that is a really normal feeling for families, that they then have the guilt of feeling that way as well, on top of the resentment. And I think sometimes just having an open forum to discuss how you're feeling can be such a huge weight off the family's shoulders. We had one client who came to us from an inpatient rehab unit, and his mum said she got this carrier bag of leaflets about brain injury, and even 18 months on, she couldn't bring herself to look at them because of the trauma. And she felt like a new mum again. She said, I feel like I've got a 31-year-old baby where I don't know how to care for my son anymore because everything has changed. And those coffee mornings just became such a relief for her to just get off her chest in an open forum of how she's feeling. So I would say, yeah, they're probably the main challenges we come across as an organisation.
I just want to touch upon that, Casey, actually, as well. Like, I think you're absolutely right. It is actually signposting those family members as well. And we are actually the point of contact, that we have that privilege to do so. So I think absolutely, I think that is one of the biggest things with community work, is being that person that you can signpost them and get them help. I love the coffee morning. Sounds great.
Thank you.
Thanks, Casey. Natasha.
I completely agree with what Casey and Eki have said. A lot of the thing that we notice in our setting in particular is we have people who have come from their very intensive rehabilitation block, where they're getting therapy every day, and they are just really going through that acute phase of change. And as they're coming to us, the gains are starting to slow down, and the therapy level drops as they enter into our service. And I think a lot of families struggle with that change. I think in the initial stages, they don't process their grief as much, because so much is changing and there's so much to focus on. And so when they come to us, that's when they really start to process what has happened to their family members. So it's really important for us to keep an open communication with the family and with the client, to make sure that they feel supported through that change, and to really hear the concerns that are coming about. Because the other thing we notice when they come to us as well is that a lot of the goals that have been set within the rehab centres are very geared towards discharge and what needs to be to set up things for home and what that's going to look like. And yes, they're all very important and appropriate goals, but sometimes they're just not what's important to the family and what's important to the patient themselves. You know, like it's great if they can stand and they can transfer, but actually all they've wanted to do for the last 3 months is get out and go for coffee with their mum, and they haven't been able to do that. So actually being able to sit down with the therapy with the family and actually reset those goals with them and make some change towards the future, how they want it to look for them, can really, really help to build that family relationship. Because I think it is just such a big period of change and they're not really sure what to do with themselves in that early stage. Yeah.
Thanks, Natasha. Hugh, I think we're all interested to hear about your perspective, because you come at it from a sort of legal and jurisprudence point of view.
Absolutely. So, I mean, what we're trying to do is to put the client back into the position they would have been in had the accident not have occurred. But of course, you know, that's pretty much impossible for this cohort of clients. I think it's important to realise, and it's been mentioned already, that brain injury brings with it often a lot of hidden deficits. So very different acting for a client with a significant brain injury to perhaps one with serious orthopedic injuries. You know, they walk, they talk. Oh, they must be normal, and of course, you know, that's far from the case. I hear a lot of lawyers talking about, you know, their role as maximising damages, and that really gets under my skin, because from my perspective, it's about first looking at how we can maximise outcome, and then, of course, making up the difference with the damages award. It's important to realise as well, I think, that the litigation itself can be very traumatising for families. It's very difficult for clients and those supporting them. And actually, even post-litigation, clients get used to having a litigation team, often for many years, which all of a sudden on settlement disappears, and there's a new period of adjustment for the client. For me, it's really about know your client, and that starts with, for example, where you see your client for the first meeting. I always dissuade clients from coming into the office. It's far better to see them at home. We shouldn't really talk about brain injury, I think, but rather the brain that's been injured. It's all about context, and you start to pick that up when you see people in their home environment. That's really important. And of course, one of our main initial challenges is around getting that rehabilitation up and running. You know, these are clients who often, when they come to us, have had very little rehabilitation. They might have had some inpatient rehabilitation, but then often discharged quite early into the community. So it's about identifying that need, looking at how we're going to commission, if you like, or start that rehabilitation. Is it through a sizable interim payment from the defendant, or are we looking at the rehabilitation code? And each has their own advantages and disadvantages. And then I think once the MDT is up and running, it's around one, letting them get on with it, but equally being enough involved that you do understand all of the issues and can take those away and try and find solutions through the litigation process. And obviously, you know, lots besides in terms of pulling together the right team of experts, including counsel, looking at who reports when and on what. The final quantification of the claim can only be done when you understand prognosis, but often prognosis can't be understood for a number of years post-injury. But that doesn't mean that you shouldn't be getting some of your key evidence quite early to help you with identifying need, meeting that with interim payments, etc. So there's a lot to do, and also a huge responsibility. But I think almost above all else, know your client.
Thanks, Hugh. That's really helpful. Pedro, issues and challenges.
Everyone nearly said everything. Not everything, but touched very important subjects in terms of supporting the families. Throughout the process, from the day that the person sustained the injury, throughout that acute period, then the discharge from hospital, intense rehabilitation, slow stream rehabilitation, the legal process, the needs of the family, they do change considerably. First of all is about what happened to my loved one. I don't understand anything about what is happening. Then the traumatic experience of seeing that person in hospital, in ITU, leaving the hospital, coming home, the adjustments that the home has to have, the adjustments that they have to do in terms of their role within the family. If he's a male that is a provider, who is going to be the provider, who is going to be the husband? Is he my husband? This is not the person that I know. Is he going to be the father? Is she going to be the mother? There is a significant change. And quite often, support is not readily available to the families. For example, at Richardson Care, we noticed that quite a lot. So in fact, what we do, we offer family forums. They are not funded. We decide it is on the best interest of the family and the patient or service user. And we offer family forums. And the grief, the trauma that we see, and the work that has to be done and could be done to support those families would be extremely important. There are services available, charities, Edway, support groups, so on and so forth. But I do not think that that support is readily available to support the families, particularly wife, husband, and children. The education around brain injury to the families is quite limited. As you were saying, Casey, I don't know if it was Casey or Aki, that someone was given flyers into a bag, and now what am I going to do with this? Just looking at the bag can trigger trauma. What you was talking about is quite important, and when I work with in medical legal cases, both families and patients, they report that, in fact, the litigation process, that becomes a full-time job. They do not understand what, in fact, is going on. And each time that they would have the medical legal appointments where the family will attend is quite re-traumatizing. And each time that they have to go through that process, in fact, is quite painful. But we expect that the person would understand that, would be able to manage that situation and move on. So support there is also quite necessary. How do we go about it? Organizations like Richardson Care and similar organizations, I do believe that they offer support to families through different channels, one-to-one work, forums, family forums, day-to-day contact with families, explaining to them what is going on, more at times on an ad hoc basis. That is what we are doing. Do we need to have something more structured from a statutory point of view, privately funded? Yes, definitely. And that is something that people should be thinking about. How would we offer that to the families and, in fact, to the person that sustained that injury?
Great, thanks, Pedro. And I promise if we go around the panel again, we'll do it in reverse order this time. So thanks for your patience, Salman and Micah. Same question to you, the issues and challenges as you see them.
Thank you very much. I would second everything that everybody literally said, and mainly what Pedro touched upon. I'm going to just build upon that point. It's quite fragmented sort of care that we see sometimes, particularly for families, when the patient is admitted to acute and then they're transferred to the rehabilitation setting and then to the community. Patients' life change overnight with brain injury mainly, and for families as well. And it's really that sort of caregiver fatigue that comes in. It's really not understanding what's happening with their loved ones, and really how they're gonna go through that journey. And also sometimes there's that level of expectation is quite different between the family members, and that lack of education as well sometimes from, that is the support is not available. So it's really about taking them through the journey. And one thing at Ascot, and Casey and Ellie rightly mentioned about the goal setting and making sure the family members are part of those discussions from very beginning, to really ensure that they are on board with what's happening with their loved ones. Also, what we do here is that we try to have those family members even different pathways to stay here on site with their loved ones. so that the patient can adjust to the new changes. We also do provide here one-to-one support for support for family members, which sometimes is not readily available in lots of other settings, to ensure that they can really, that the grieving element of it and acceptance element of it, they can really overcome it quite successfully. So it's really about taking them to the psychosocial element of it as well, because it's not really about taking the patient back to what they were originally before injury. It's really about how the patient is going to live with what they have now, and making sure that there's right support for them available throughout the whole journey, really.
One thing which has been touched upon a little bit before already, but for the family, it's from, as you said, an overnight situation. So in comparison to other, let's say, indications or diseases, let's say MS or brain tumors or so, when it's a progressive process over time, this is something which hits the patient and the family completely in the unknown, and leaves them with all these deficits about where's the level of education about it, expectations, etc. So I think this is a very important point to underline there again. Also in terms of communication, depending on the severity of the brain injury, often enough said patients have difficulties in cognition, in communication. So therefore, the family is also very important to convey messages and feedback on their knowledge of the patient over the years before, for us to have the necessary information. Also, patients in their state when they come to us, they need obviously a time, and probably even longer than other patients' time to settle in. Therefore, the new phases around them of the MDT are a challenge, whereas again, the family members, they can relate to easier. And again, this is a good communication bridge.
Thanks, Micah. If I can open up the discussion now, we've talked about issues and challenges, but I think those watching will want to hear about how NR professionals, organisations, MDTs can support recovery, rebuild lives, support families and loved ones. Can I just ask panelists, and this is open to any of our panelists, to talk about some of the successful interventions that they're aware of or have been involved with, to give us some examples of how those interventions can make a significant difference? Casey.
Yeah, of course. So I was just going to chat about one of our clients, actually, who we started supporting, 3.5 years ago now. And it was 15 years post him sustaining his brain injury that we started supporting him. And unfortunately, when he was involved in the accident that gave him his brain injury, his daughter was only 6 weeks old. So they had never had any chance to form any kind of relationship, really. They had a very fragmented relationship. He does present with frontal lobe paradox, and he's also very, I would say, kind of impulsive. And he will quite often say things that he doesn't mean, so was quite prone to unintentionally upsetting his daughter, especially where, because she was a young child, she had had no education or input around her dad's brain injury or what that meant for their relationship. And rehab for us is, yes, being with the MDT, it's physio, it's speech and language therapy, it's occupational therapy, it's all of that. But it's also giving that person a chance to do something they would have done pre-brain injury. And that to me is just as important for rehab as those physio sessions or those SALT sessions. If that's a holiday, if that's a night out, if that's going to a music festival, that is also rehab, because that's allowing that person to lead the life they want to lead. And he had expressed that he really wanted to build a relationship with his daughter again. So we reached out to her mum and started just doing kind of, because she was a little bit older, she was 15 at this point, started doing little sessions with her around her dad's brain injury and what that meant and what it may look like. And myself and one of our other managers, Erin, actually took it upon ourselves to build a relationship with her. And we started introducing fortnightly coffee dates. So they would meet in Starbucks for a couple of hours. They would have a catch up. We would kind of prep him with questions and what to ask, and divert him if he did start, being slightly inappropriate, or we thought he might unintentionally upset her. And it actually got to a point that last year she agreed to go on her first holiday abroad with her dad for over 16 years. So we took her dad and her away to New York for Christmas on their first father-daughter trip after kind of 3 years of education for her, education for him, and building up that relationship slowly from fortnightly coffee mornings to then it went to a dinner one week and then a coffee morning the next, and then dinner once a week. And finally up to that kind of 5-night away trip to New York over Christmas. And it was just the most wonderful thing to see. I mean, I was fortunate enough to go and watching them kind of ice skate in front of the Christmas tree at the Rockefeller Center together, and taking pictures of them together. It gives me goosebumps now even talking about it. And I'm currently in the middle of planning their next father-daughter trip, which I also have the privilege of attending, and we're going on a 2-week Caribbean cruise for his 60th birthday. And she also now has just passed her driving test and actually drives herself over to her dad's to see him without Erin or I present. So we've given her the skills and the tools and the confidence to, divert her dad sometimes when he is being a little tricky, which he can be, and also kind of give him the tools to recognise maybe when he is starting to upset her and recognise that himself. Because it is so easy to talk about all the issues we face with families, and it is easy to forget that the work that we do over time and building up those relationships actually do have a huge impact. And it's allowed a young woman to have a relationship with her dad, and also a person to have a relationship with his daughter. And it's just been wonderful to watch it unfold and to carry on watching it build. And I just thought it was really important to also share those kind of positive stories as well as the challenges we all face.
Wonderful example, Casey. Thank you.
I was going to say something too. That is really a very nice story, Casey. Really, really, really nice. Well done. But what I wanted to say is something that you touched that is quite important, is the length of time that is required to rebuild that relationship, and is the investment that we have to have with the family. So is really working with the family, supporting them to understand, in fact, what has happened, what will happen, and how you will respond. And it's also important to make them aware how they have to adjust to that, and how to accept that change. In that case, was a young child, possibly was slightly easier. But if it's someone around the age of 15, 16 that already knows the father, and then or the mother, and then there is a significant change, that work is quite important. And it's also important sometimes to understand that we are given always, or asked to give, a timeline of when is this going to be done? When are we going to reach the goal? And that is quite challenging as a therapist to say, well, we don't really know. It's a progressive piece of work. It will improve, but is it 6 months' time? Is it 6 weeks piece of work? Things are dynamics. Relationships are dynamics. There is a very complex dynamics in those relationships. But yes, I think what you touched there is quite important, is sometimes work more with the family and then support the service user or the patient to understand what is going on and rebuild that relationship. Yes, that is really the dot.
Yeah, and it is really difficult to put a time on it. It took us 2.5 years to get them to a point where she was able to spend a long weekend. And I know it was in New York, but have that overnight trip with her dad. And it was 2.5 years of weekly visits, and it took a long time, but it was absolutely worth it, and it's just building on that now.
But did you have a specific intervention that was discussed within the team to deliver that piece of work? Were you funded for that, or was part of the rehabilitation package to support the family?
When we met with him, when we got the referral through and we did his assessment, as part of our assessment process, it's always, what do you want to achieve from your support? Why is this important to you? And he said, I just want a relationship with my daughter. And so we sat down as a collective with the case manager and the financial deputy as well, and said, how can we make this work? And because his daughter was a young woman, she was 15, 16, and it did need quite specialist intervention to allow him to rebuild that relationship, we agreed that it would be management that actually started that wrote guidelines and then passed it on to kind of rehab support workers. And the deputy, you know, gave us extra funding to facilitate those coffee evenings and dinners, which that is all we charge for, is the time we actually spend at those dinners, not for any of the admin input behind the scenes. And yeah, we agreed a plan to start, you know, I said like fortnightly coffee dates, and kind of just at her pace, let his daughter lead what was going on, because at the center of it is, yes, a vulnerable adult, but also a child, and let her lead what is going on and the pace she wanted it to move at, and take her direction, her mum's direction as well. And we did have to present quite a detailed plan to her mum, because understandably she was worried. It's her little girl, and it could have been, again, opening up trauma for her. I mean, luckily it was a really positive experience, but there was a lot to navigate, and a lot of moving parts, and it took an input from management, from the rehab support workers, day to day, on the ground with the client, kind of reinforcing what we were doing on those visits, as well as the MDT.
Thanks, Casey. Any other examples of successful interventions?
Yeah, I would just like to build upon what Casey was saying. And I think the most important thing that Casey mentioned is the slow transition of the element of slowly transitioning the patient back to community, and how the family is able to support. So one of the examples that comes to my mind is one of the patients we had quite severe aphasia, so quite communication problems he had. So what we did is that we had the wife living on site to really relearn the new communication methods that we were trying to do as an intervention here, to really understand how she can communicate better. And also then slowly transitioning the patient back to community in a way that initially we begin with having the patient going on the weekends to the outings, different sort of, their family settings, and some back to their friends and families, basically, whenever they were going in during the weekend. And then after, the successful period initially, the family, we did allow them to basically go over the weekend to stay at home. So we had this hybrid model where the patient was here during the weekdays, and during the weekends, the patient was going to home, instead of directly discharging them straight to community. And in the end, when the patient was really ready and the family was able to really, adapt to those new communication methods, the patient was discharged home. So that slow transition really did help that patient and the family on the way out. Yeah.
Thanks, Salman. From the panelists we haven't heard from, Eki, Hugh, Natasha. Natasha, did you want to come in?
Yeah, I was just going to agree as well with what Casey was saying in terms of how important it is to focus on both sides of the relationship, and how hard it can be when you are so far down the track. We had a gentleman, for example, who sustained his injury when he was quite young, and the injury itself was also quite traumatic, both for him and the family, and his hospital experience was very traumatic. So by the time he came to us, he had a huge distrust in the healthcare system itself, and in social services. So he was sitting with us while he awaited a placement for a home, waiting on the housing association to find him a suitable house for him and his family to be able to move into. He ended up with us for 5 years, and the housing had almost reached a stalemate. And we were very closed off from being able to come into the housing discussions initially because of the distrust there. I think a lot of what we did really was just the simple things that I'm sure everybody is familiar with, but it's that open communication, it's those little check-ins, it's those things that make the family trust in you and the patient trust in you, that you are someone that they can go to. And, if you say you're going to do something, actually being there and following through with it, so that they know that they can come back and count on you. And in the end, just doing all these little things. And also we reset the goals with this patient so that the goals were more meaningful to him, and it made him feel heard and allow us in. But he ended up allowing us to put forward information into the housing discussions and provide feedback about other ways to tackle the issue, because the issue was that they couldn't find a house that was big enough for the wheelchair and the family and he ended up allowing us to suggest maybe they look at different housing solutions, like housing next to each other. And after 5 years, he is now moving into his own home and within the next month. So yeah, I think it is. It's just that open communication and really giving that good, allowing the family as well to say what's important to them. Because up until this point, I think they'd felt that the housing didn't understand how important it was that they stayed together as a unit.
Great, thanks very much, Natasha. Hugh.
Yeah, I mean, it's always useful, isn't it, to do it by way of a case study. But we of course, like to see all clients from the minute that they first instruct or want to instruct solicitors. But actually, one of the very successful sort of niches, if you like, that we've developed at Enable Law is that of taking over cases partway through. And there are far too many solicitors out there, unfortunately, dabbling in an area that they're just not equipped to deal with. I'm thinking of a case that we successfully concluded in the run-up to Christmas last year. A client very seriously injured in childhood. Mum had initially been signposted to a firm of solicitors who actually specialised in very low value, high volume claims, and it was actually the case manager who said to the family, "Look, I really think you should think about switching your instruction," which they did, and also then the Court of Protection deputyship as well. Defendants just had not appreciated the full significance of the head injury. I think in large part because the solicitors hadn't evidenced it properly up until that point. So we had to sort of rebuild the team of experts. We had to sort out accommodation issues. There were lots of quite complex mental capacity issues, and in fact, one of the biggest changes in my practice over the last 10 years has been mental capacity, and not just talking about financial capacity to manage property and affairs, but all the health and welfare related issues. So for this particular client, that as well was an issue, and we had to focus quite early on issues such as her capacity around contact with others, social media and internet use, phone use, sex and relationships, quite a lot of sort of knotty issues that the MDT were also sort of focusing on at the same time. And I think certainly there was quite an innovative approach to a lot of that, but ultimately really useful evidence then to have in the claim. The defendant's first offer, just to give you a sort of an understanding of the lack of sort of getting to grips with the matter that sat with them, their first offer was £1.5 million. Not interested at all. The client had by that stage £800,000 worth of interim payments. The next offer was 10 million, big increase, still not there. Case eventually ends up settling at 27.4 million. There is no way that outcome would have been achieved for that client had she remained with solicitors that didn't have the expertise to deal with it and to grasp and have that understanding of all these quite complex issues around rehabilitation, the right MDT, mental capacity issues, etc., etc. So I think from the litigation perspective, again, it comes back to know your client and the issues involved, and building that person's life up again, really, from what's probably their lowest point.
Yeah, that's a brilliant illustration of the need for the best possible advice and support and guidance. Eki, before we move on, do you have any examples that you want to share of successful interventions?
Yes, just a few. So yeah, I think from all of your discussions, I think why we kind of come to the idea of having a client and family liaison at the BIS Services was because of all this. I think we wanted to showcase that actually families had a point of contact to actually share any insights or any concerns, or like you said, Pedro, as well, just have a voice so that they felt heard. So we do have that facility at the BIS Services where we have that person checking in with families and clients regularly. And we think that's really helped. It's kind of bridged that gap, because sometimes with MDTs and, you know, the support on the ground, you can't sometimes share those concerns. It's too familiar in there, and actually having someone maybe not so connected can sometimes actually be really helpful. And I think probably the next kind of good example that I have is, you know, a lot of our clients actually have become, like Casey, have become parents after their brain injury, and supporting that relationship can be really important, but actually supporting when relationships don't succeed, and managing breakups and relationship failures is probably one of the most important parts of the work that we do, because actually we are the people that are so familiar and, like Kay said, on the ground consistently. We get to know the client so well, and actually that piece of work, how do you manage those breakups, those failure in marriages, relationships, and actually then if there's children involved, also managing that aspect. And I have a really lovely, just a success story of, you know, one of our, she was a young client. She was only in her 20s, and she had her child after her brain injury with her partner. And quickly we noticed that her behaviours turned quite aggressive, and she did have epilepsy as well. So postpartum, she did actually have seizures as well. So the risk of her parenting became heightened as well. But what happened with that, the lack of education and insight from her partner really started to show. So what she was actually masking very well without the baby, he could manage. But as soon as there are extra responsibility happened with the baby, he soon realized actually how significant her brain injury was. And actually he admitted that he didn't have insight into this, and maybe wouldn't even have a baby with her if he had knew that. And that was really hard for our client to hear and actually accept. So we actually had to support her with managing that breakup, but then also being a parent to this child. And I think what we really love to see was actually she does have such a good relationship, and is actually a better parent now because she doesn't have the capacity to be a partner and a mum at that time, but now she can focus on just being a mum, and we can support her with that. And that's what's worked really well. And I just want to say, parenting is difficult without a brain injury. Supporting a client with a brain injury, being a parent, actually showed us how many gaps there are in just parenting groups. Soft play is a nightmare. Any parents out there, soft play is a nightmare for any parent, but with a brain injury, actually navigating, we actually had to have relationships with soft play areas to say, can you tell us what non-peak kind of, you know, hours, so we can go there when it's a bit quieter, or actually cornering off certain areas. So having those kind of conversations, I don't think there's enough education out there for parents with a brain injury, and actually accessing groups, workshops, soft play areas. I think there's a lot more work, and I think that's what we're really keen to do at the BIS, actually raise the standards for childcare provisions in the community for people living with a brain injury.
Thanks, Eki. I think there's
just
sorry, Hugh, please come in
very quickly to that, and I think it's obviously incumbent on those conducting litigation in this area as well, that there's that understanding that life isn't a linear line. There are those lumps and bumps along the way, relationship, you know, breakups, bereavement, illness, etc. And it's very important that when we are quantifying claims, that we're making sure that there's sufficient provision for those contingencies throughout life. And I think frequently there's not enough consideration given to that.
Thanks, Hugh. Thanks, Eki. I'm going to start to draw things to conclusion by going round the panel once again. Before I do that, is there anything that we haven't talked about that anybody particularly would like to raise? Well, if not, I'm going to ask all of our panelists just to say a few words in conclusion about their hopes for the future.
What we have heard here repeatedly is the slow transition into community, particularly then also in our case where the patients are on a more acute stage when they're still coming from hospital. And I, for example, think of Casey's success story when the patient's already then able to travel to New York, then that would involve a long time from when we see patients to a situation like in the example, meaning that the best results are achieved when the patients are seen as early as medically possible, but that also as long as possible, where the question of funding comes in. And when I hear earlier the example of the litigation sums between 1.5, 10, 27 million pounds, then I think the cost of the acute rehab and intense rehab, as we do, is relatively minor in comparison. And it is a very, very good investment at the beginning when the patient has the most potential to improve, not to have limitations in that sense, but being able to get the optimum out of the situation. Hence, funding for that is an important issue.
Great. Thanks, Salman. Thanks, Micah. Pedro, final thoughts, those things that are going to make a difference in the future. Pedro, I think you're still on mute.
Yeah, sorry, I noticed now. I said that I was thinking alongside of what Michael said, and what you was talking about, and I think that interlinks. That is, the road is a long road, is a bumpy road. Funding is quite important. I think both with Eki and Casey's examples, that just showed how long that process takes, the investment, and sometimes what are the needs. We are talking about someone with a brain injury to be a father, to be a husband, to be a wife. Are there any services available? When we are talking about funding, is funding thinking about those things, or are just focus, as Mike was saying, in terms of the acute rehabilitation, the physical aspect, the challenging behavior, the making sure that the patient leave an acute service and go home, and then what is waiting for that person in the community. And I worked, for example, with cases where BIS was involved, and the support that they offer is great, but is not enough. But then there are these ideas that if we had parenting groups in place, family therapy, counselors to address the relationships, they are there. Are we using it? Is there any funding for us to reach to those services? So I think that is paramount. Of course, we could develop some services. I think we all have an idea of services that would benefit the person. Is about how do we go about it? How do you reach them? How can we get access and funding to access those services? And of course, artificial intelligence is coming in, and I'm sure that will bring a lot of solutions to many of these challenges.
Great. Thank you, Pedro. Hugh, the future?
Yeah, I mean, life is ever more complicated, isn't it, every day? And for those with a brain injury, it becomes more and more difficult. And I do think that there's an important role there for AI to make things easier for our clients or patients. I was quite interested to see the recent NICE recommendations. Recommending a standardized approach for rehabilitation, addressing the variation in care experienced by millions of people around the country. So I think there's some catching up work there to be done. I think brain injury often, and because of its hidden nature, doesn't have enough sort of prominence in terms of our governance and central resourcing. So I think a lot has been done, but there's still an awful lot to do. I find that litigation, I'm lucky. It's often at the forefront of these things, but I do realise that for lots of patients that don't have the opportunity to recover, damages, to fund, their rehabilitation, that it is a big challenge, a big challenge.
Thanks very much, Hugh. Your reflections, Natasha?
I think my hopes for the future really is and I feel like at the moment we have a very person-centered model of healthcare, but it often means that we take the person as they are and we look into them and we see their issues. And so I hope in the future that we move towards a more holistic view, so that we can really find these issues early and really be able to help the families early and help the patient early with the things that are most important to them. And I think that that is a funding issue, as you have all identified, and actually where to direct these people. But I think if we identify early what their goals are and what they want their future to look like, then we can better address them, so that we're not years down the line with these people then trying to backtrack and fix all of the inequities that have come.
Great, thanks, Natasha. Casey?
I think I touched on this earlier, but I think I would hope for more education in statutory services around brain injury, and because as Hugh's touched on as well, it is a lot of the time hidden, and a lot of the time because someone can walk and talk, they are seen as okay and not needing a level of input. So I would say massively for more education in statutory services around brain injury and what that can look like. And also then leading on from that, kind of identifying that actually it's not just the person who sustained the injury that's gone through the trauma, but it is the family and the fallout from that as well, and being able to introduce more services. I know, we provide them. Eki, you've mentioned, obviously you have a service for families as well, and I'm sure everyone on this panel does. But we fund that ourselves because we've recognised a need, and I think the government and the people who provide funding also need to recognise that there is a need for family support, because they have also sustained a huge amount of trauma. They've had to, like I said, watch their loved one in ICU and grieve who their loved one was and relearn them, and that is huge. And I also hope that in the future people can take on a positive risk-taking approach with the people they're supporting and enable them to do the things that they would have done pre-brain injury. And I think Natasha touched on it, not just looking at the person they are now and who's sat in front of you, but actually looking at the person they were and how we can help them to, if they want to, get a small sense of their old self back. And for us, that's then a successful provision. If we can give them a small slice of their life pre-injury back, then we've done a good job.
Thanks, Casey. And Eki, you get the final word.
Oh, pressure. But I just want to echo what everyone else has said, to be fair. I think for everyone here, I think what I'm hearing is it's an integrated, holistic approach that's needed to work with people with brain injury and their families. And I think education is so important, not just for the family and the clients themselves, but as professionals. I won't sit here and say we're experts in family, but I think we all work with families enough to be able to make sure that we are keeping up with NICE guidelines or other regulatory bodies as well. So I think key is integrated, holistic, communicating with each other, and just making sure that we are keeping up to date with all the different approaches and regulatory bodies.
Thank you, Eki. And on behalf of NR Times, can I just say a very all of our panelists for sharing their experience and their insight with us today. It's been a wide-ranging discussion, I think, with a very positive conclusion. And for anybody interested or involved with surviving brain injury, I think this is essential viewing. So for all those watching, please share this as widely as possible. This discussion really does deserve to be seen by as many people involved in the brain injury community as possible. So thanks once again on behalf of NR Times for watching. Thanks to our fabulous panelists, and enjoy the rest of your day.